coronary artery, normally we talk about coronary spasms, talk about coronary stenosis, but the major cause is the plug forming within that would obstruct the flow, cause a mechanical obstruction to the flow of oxygenated blood to the myocardium. So the pathophysiology is what I'm going to talk about. So the first thing that you should appreciate is that the vascular endothelium of the coronary vessels plays a critical role in maintaining the vascular integrity and homeostasis. The vascular endothelium very important. The vascular endothelium is very important. Anything that affects the integrity or changes the integrity of the endothelium would initiate atherosclerosis. So you have the vessel. The vessel is very, very important. The integrity of the vascular endothelium of the coronary arteries are very, very important. Anything that changes the integrity could initiate atherogenesis. You get what I'm saying?
Yes, please.
So what are the things that could cause changes such that atherogenesis could result? What are some of the conditions that could change the integrity of the endothelium of coronary arteries that will predispose the coronary arteries into plaque formation or atherogenesis? What are some of the conditions? So we have biochemical abnormalities, conditions, biochemical abnormalities. These biochemical abnormalities could cause damage to the endothelium. So when a patient comes with diabetes, we say that diabetes is a risk. Why is diabetes a risk? We said it's a modifiable risk factor. Why is it a modifiable risk factor? We talked about elevated LDL. Why is it that elevated LDL is a risk? So these elevated diabetes, all these could cause damage to the endothelium. And the type of damage that it can cause is non-denuding form of injury. Non-denuding form of injury. Non-denuding form of injury are injuries that will not happen spontaneously. The thing will be there. Now, if you have diabetes, the diabetes will be there. If you don't take care and manage it, this diabetes, one, could serve as a good medium. The hyperglycemia could serve as a good medium for microorganisms to thrive on. And these microorganisms, when you allow them to thrive on this hyperglycemic state, infections will ensue. And infections will cause inflammation. So they will cause inflammation to the vascular. So when they cause inflammation, they will change the integrity of the endothelium. They will change the integrity of the endothelium. Again, we have hyperglycemia. Hyperglycemia could cause elevation of the lipids. The elevation of the lipids, you could have the position. When you have lipids, some of them will deposit within the vessels. And the position of lipids, this is non-denuding. Lipids should not be. They are not supposed to be deposited within the vessels. And when they deposit for long period, they will cause damage to the endothelium. The thing will be there, you will not see it. But at the end of the day, it will cause damage. Do you have a Muslim among us? Do you have a Muslim among us? Yes or no?
Yes, please.
So, Bawa, when you are praying, I just want to ask you something. That is non-denuding injury. You want to use that to explain the non-denuding injury. When you are praying, or why is it that you have a black spot at your forehead? The Muslims, they have black spot at their forehead. Bawa, are you there?
Yes, please.
Why is it so?
It's because of our constant putting our head down during prayers.
Does it hurt?
No.
It doesn't hurt. But
yes, please.
Before you say Jack, you'll be seeing that black.
Yes, please.
Under normal circumstance, it's not there. So it's not there.
Yes,
but
please.
With constant praying, this thing comes. This is non-denuding. It's there. There's a damage. Other than that, the place will not change. Non-denuding injury is an injury that will not happen. It's not something that happens. It's a nice way, but at the end of the day, something will happen. You will not be seeing it, so your mind will not come on that. That is non-denuding. It is not going to happen at spontaneous, something that would draw attention. It's not going to do that. It will be there. But before you realize there's a damage. Now the black thing over there is not normal. What is that? Is it blood? Bawa, is it blood?
No, please.
It's what?
Sometimes it just happen with time. I mean, sometimes we ourselves, we are surprised we notice it. It's not painful as you said.
It's not, that is non-denuding. But at the end of the day, there's something going on. Because it's not normal to you. Do you get it? So
Yes.
when you talk about non-denuding, it's something is happening, but you will not realize it. Now, if you have diabetes, the diabetes is there. You not realize, before you realize, then it has caused a plaque. Plaque will form within the vessels. Why? Because if you don't manage the diabetes well, infection can ensue. If you don't manage the diabetes well, it could lead to dyslipidemia, could cause elevation of LDL. And this LDL would deposit within the vessels. So when you don't manage the deposition and it's there for a long time, it's tend to cause a damage because lipids are not supposed to be in there. And when it's deposit, even when you eat and some of the oil deposit within your tongue, you feel uncomfortable. Why? Because they are not supposed to be there. So when it's there for some time, you will not be comfortable. So the non-denuding injury are angry, you will not notice. It does not happen spontaneous. It's something that happens. We use insidious. It starts and you will not notice. Before you say that it has happened. So this diabetes, we have smoking, cigarette. These free radicals from the smoking could cause inflammation to the endothelium, and this could be a long time. Inflammation from infection, diabetes, elevated LDL. These are all biochemical abnormalities, such that if you don't manage this, it can cause non-denuding form of injury to the endothelium lining. And when there's changes in the endothelium lining, then it could initiate atherogenesis. Please, do you get it? Do you get it?
Yes.
Another thing that could also initiate atherogenesis is, we call it mechanical shear stress, high BP, morbid hypertension. This morbid hypertension can also cause. So if we say hypertension can cause a plaque forming within the vessels, and if we ask to explain, you should know how to explain. What happens is that this hypertension, we term it as morbid hypertension, can cause mechanical shear stress, can cause a tear. The pressure buildup within the vessels can cause a tear as a result of this morbid hypertension. The flow, sorry, the flow of blood within the vessels, the flow of blood within the vessels. And this can cause a tear. So we term it as mechanical shear stress, causes a tear within. And because it has caused a tear, then the integrity is compromised. The vascular endothelium is compromised. So I'm saying that the integrity of the endothelium is very, very important. Plays a critical role in maintaining the vascular integrity. So note this. Anything that changes the integrity could cause initiation of atherogenesis. So those biochemical abnormalities can cause non-denuding form of injury, and this will also cause the integrity to be compromised. You have high BP, and this high BP, which is termed as morbid hypertension, can cause shear stress, and cause a shear stress, and this shear stress would initiate the atherogenesis. So how is plaque formed? How is plaque formed? Do you need this or I should move on? Hello?
Hello.
Should I skip this or I should take you through how plaque is formed?
Sir, please take us through.
Okay, so the first thing that will happen, I'm outlining how plaque is formed within the vessels, especially the coronary, to cause coronary artery disease. So the first thing that happens is that if there's an injury, see the endothelium, if there's an injury, whether it's through the non-denuding injury, whether it's through the morbid hypertension, mechanical stress, it's an injury. Anything is an injury. The moment we have an injury, now what will happen is that certain substances will move to the site of the injury. Certain substance will move to the site of the injury. Let me say this. I was talking about lipid deposition. So the lipid deposition within the vessel, normally we term them as fatty streaks. The buildup of lipids within the vessels, we term them as fatty streaks. And this starts at the younger age, 10 years, then there's a buildup starting from 10 years. So if you don't exercise, that's why exercise is good. If you don't exercise, such that you can burn these fats and this deposition, this can cause. It can initiate plaque if there's non-denuding injury. So when there's an injury, it means that the endothelium is compromised. And the site of the injury, what will happen is that certain substances will move to the site of the injury. That is a compensatory mechanism. Certain substances, they are doing that just to offset. It's a compensatory. Just make sure that nothing happens. The system is going to normalize itself, but at the end of the day, other things can ensue. So there's a site of injury, and these substances, fatty streaks, smooth muscle cells, platelets, and collagen. Fatty streaks, smooth muscle cells, platelets, and collagen. These substances will move to the site of injury. These substances will move to the site of injury. So we have smooth cells, we have platelets, we have lipids moving into the site of injury. Is it clear up to this point?
Yes, please.
Yes, please.
So that is the first thing that will happen. There's a site of injury, certain substances like fatty streaks will be there, proteins, lipoproteins. We have macrophages, platelets. All these substances will move to the site of injury. When they get to they gather at the site of injury. When they get to the site of injury, what happens is that macrophages will then go at the site of injury. Macrophages will then engulf all these substances. Macrophages will engulf at the site of injury, and they will form what we call lipid laden fold. They will form what we call it as lipid laden fold. Lipid laden fold. Lipid laden fold. That is the second process. I want to break it down for you to understand. That is the second process. The first is there's a damage to the endothelium. Second thing is that substances, macrophages, lipoproteins, monocytes, platelets, all these substances will move to the site of the injury. When all these substances move to the site of injury, what happens is that macrophages would engulf and form lipid laden fold. That is the beginning of the plaque, lipid laden fold. So the next thing that will happen is that then cytokines, we call something cytokines. The macrophages engulfing all these substances will release substances called cytokines. So macrophages release. Monocytes will also release cytokines. And these cytokines, what these cytokines does is that these cytokines will stimulate the growth of the lipid laden foam. They would now invite more macrophages. They invite more monocytes. They invite more things that will promote the growth. So basically what it does is that the cytokines produced or released by the macrophages, released by the monocytes, these will stimulate the lipid laden foam to grow. So it starts small. Before you say jack, then it will occlude the whole vessel. So it will start like a lipid laden foam. And within the lipid laden foam, we have a lot of lipoproteins, we have platelets, we have monocytes. All these will be there. And these macrophages, these monocytes, will cause the release of cytokines. And these cytokines will stimulate the lipid laden foam to grow. So they will ensure that there's proliferation of the lipid laden foam cells. There will be proliferation of that. Examples of these cytokines that are produced. Are, we call one transforming growth factor. So they will cause growth. So transforming growth factor beta. And the other one is platelets-derived growth factor. These two cytokines will cause stimulation or proliferation of the lipid laden foam cells. Please, is it clear up to this point? Do you understand?
Yes, sir.
So that is the next step that will happen is that the smooth cells, now there's a damage to the endothelium. So that area which is damaged will release what you call collagen, substance called collagen. And these collagen released will form a fibrous cap. The collagen that's released now, what will form initially is a lipid laden foam. So it's not something strong. The initial plug form, which is a lipid laden foam, is a foam. So it's not strong. So when the site of an injury releases collagen, this collagen will now cap it, form a fibrous cap. And this fibrous cap will harden the surface. So the site of the injury will release collagen, and this collagen will form a fibrous cap that will cover. So we have cytokines causing the growth of the plaque, and we have collagen that will also cover. The collagen will cover, forming a cap that will surround it and form a plug which is hardened. And so this plug will grow, and if you don't manage it, this plug can grow and occlude the whole vessel. If it's coronary artery, it will grow and occlude the whole vessel. So if it's occluding the whole vessel, we term it as transmural. When you have total occlusion, we term it as transmural. When you have total occlusion, when it grows to a point within the lumen, it grows to a point, and it's not causing total occlusion to the lumen, and it's causing a partial occlusion. We term it as mural. We term it as what? As mural. So partial occlusion within the vessels, we term it as what? As mural. Total occlusion, we term it as transmural. So this is basically how plug is formed. Basically how plug is formed within. Any question up to this point? Any question up to this point?
No, please.
Okay, so let's talk about this plug forming who at the end of the day cause obstruction to the flow of oxygenated blood to the myocardium. And then when they cause, what will happen when you cause the obstruction? What will happen is that now they are depriving the myocardium from getting what? Oxygenated blood. And this will lead to myocardial ischemia. At the end of the day, lead to myocardial infarction. Myocardial infarction. Okay, so when this leads to that, at the end of the day, it will cause the chest pain, which is angina. So chest pain coming from the heart is termed as angina. Angina. Okay, so let's talk about angina. Let's talk about angina. So angina. So we said that the chest pain coming from the heart is termed as angina. There could be a chest pain coming from other sources. Chest pain coming from other sources. Chest pain coming from other sources could come from GI, but one coming from the heart is termed as what? Is termed as angina. So how do you describe the chest pain? Who can tell me the description of the chest pain? Angina, what would be? How do you describe the chest pain? So if a patient comes with chest pain coming from the heart, which is angina. How do you describe the pain?
They feel some heavy or squeezing at their chest.
So they feel some heavy.
Yes.
So you describe the chest pain as heavy or gripping or tighten. So gripping, tighten, or heavy. This is what the patient will be telling you. What again can we? What again?
And please, it usually radiates to the neck, the back, or the shoulder. It's usually radiating in neck.
Come again.
The pain usually radiates to the neck, the shoulder, or the arms.
So the pain is, you are right, the pain is central. The pain is central. Is in a retrosternal. Retrosternal. That is the central. Retrosternal. Behind the sternum. The pain is central. The next thing is that, as you said, it radiates. Radiates to the jaw, it radiates to the arm, it radiates to the neck. So when you have a chest pain radiating to the jaw, to the arm, then that chest pain is coming from where? Coming from the heart. What would be the description of the chest pain coming from the GI? What could be the
burning sensation?
There will be burning sensation. 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 So that's know the difference. For the GI, there will be burning sensation. For angina, there will be gripping or tightening or heavy. And the pain will radiate to the jaw, radiate to the arm, radiate to the neck. That is angina. Is it clear, class, to everybody?
Yes, sir.
So let's talk
Yes,
about
indeed.
let's talk about types of angina. Hold on for me. Hello.
Hello.
Okay, so let's talk about types of angina. So what are some
Whether you're an entrepreneur or a small business owner, you know
what are some of the types of angina? What are
That means we have presmental angina.
So you could have presmental angina. What again?
Stable angina.
Stable angina.
Stable angina.
Unstable
Unstable
angina.
angina.
Unstable angina. What again?
Nocturnal angina.
Nocturnal angina. What again? What again?
The decubitus angina.
Decubitus angina. Decubitus angina. Okay, what again? So unstable, we have nocturnal, we have another type called Crisindon. Crisindon angina. Crisindon angina. So these are the old type of the classification. Who can tell me the new classification? Who can tell me the new classification of angina? These are the old types. We have unstable, we have stable, we have nocturnal, we have virulent angina, unstable, and what are the new classification? Who can tell me one? Okay, so the new classification, all that you were talking about are now the new classification. One, we have obstructive coronary artery disease. It's come back to the same, the old. And the new classification talks about obstructive coronary artery disease. The second classification is non-obstructive coronary artery disease. Non-obstructive coronary artery disease. The last one is spontaneous coronary artery dissection. The last one is spontaneous coronary artery dissection. These are the current classification of angina. So let's talk about the old classification. So we have stable angina, which is angina pectoris. So we can also call it classical or exertional angina pectoris. Classical or exertional angina. So this angina, what happens is that this angina is provoked by physical exertion or emotional stress. This type of angina, stable angina, is provoked by physical exertion or emotional stress. So note these things, note what I'm going to tell you. Patients with stable angina will come with plaque forming within the vessels. And that plaque forming within the vessels has this property. Is the plaque forming obstructs, the plaque form doesn't cause total obstruction. There's a partial obstruction. So it impedes the flow to a point. There's partial obstruction of the lumen of the vessels, partial obstruction of the lumen of the vessel. Take note of this, there's partial, such that when you are exerting yourself, there's a physical activity. They had to be demanding for more. But because there's partial obstruction, as a result of stable angina, partial obstruction, the heart will not be able to get enough oxygen. That's why we see that the situation will stabilize when a patient gets rest. Meaning that now the patient is resting, the heart will not be beating fast to demand for more oxygen. Do you get it? So when you are not doing any activity, the heart is resting. There's no activity, the heart rate will not be increased to demand more oxygen. Therefore, there won't be any episode of stable angina. So for stable angina, this situation, stable angina patient will come with episode when you provoke it by eliciting physical or by doing activity, or there's a physical activity, physical exertion, or emotional stress. When you are stressed up, emotional, could also trigger that. So if I ask, what are some of the things that could trigger stable angina episodes? What are some? What are some of conditions that could trigger episodes under stable angina?
Exercise.
Come again.
Exercise.
Exercise can do that. What again?
Stress.
So stress, emotional stress. I talked about that, and you're telling me what again? What again?
Anxiety.
So the stress and anxiety, you are just coining around it. Tell me, what are the things that could precipitate angina?
So broken heart.
Any broken bread. Who said broken heart? Who said broken heart?
Say please, Benedicta.
Ben, I told you I want to see your face. Where is Ben?
So I'm here.
Broken heart will cause angina. So the ladies prepare for more angina cases. The men prepare for more angina cases because of broken heart. And then it's talking about infection. So other conditions or other situations that could precipitate angina, So when you have heavy meals could precipitate that. Windy weather Windy weather, one walking into the wind, windy weather can also precipitate that. Cold air can also precipitate that. And anger and excitement can also do that. And data, broken heart is not part of it. Why?
Yes, please.
So when you are excited, when there's anger, it could precipitate that it's not broken heart. When you have anger, it's not broken heart. Why? Cold air after leaving a warm room can cause that. Windy weather can also cause that. Walking into the wind can also cause that. So these are some of the things that could precipitate stable angina. But do you know what? For stable angina, we say that it's provoked by physicalization. Therefore, if you want to subside, if you want the pain to fade away, then what can you do? Cause the pain to fade quickly. What can you do within minutes? So resting is one. Resting relieve the pain. What again?
Taking
Resting and what again?
can be relieved by nitroglycerin.
Come again. I'm relieved by what?
Can be relieved by nitroglycerin.
So can be relieved by medication. Hey. Can be relieved by medication. So medication can be relieved by rest and what again? So rest using medication like nitrates. What again? The last thing that could. The last thing is what?
So walking pain.
What does it mean?
You endure the pain, and then as time goes on, the pain will go.
So walking through the pain. So you endure the pain as you said. Then with time, the pain becomes normal. Initial stages will not be easy, but with time you become used to the pain. So walking through the pain. So 3 things that could be done. But the third one is not a funny thing. Walking through the pain is not easy. Resting is cheap. Using medication is cheap. But walking through the pain. So with time, you become used to the pain. The ladies, at times, you have these menses, there will be severe pains, but you walk through the pain. You come for lectures. So with time, you'll be listening to the lectures. With time, you will not feel the pain as you used to. So walking through the pain will also help you have the relief from stable angina. Is it clear?
Yes.
Okay, nocturnal angina. Nocturnal angina. This nocturnal angina occurs at night and may wake the patient from sleep. It occurs at night and it will disturb the patient's sleep, wake the patient. There will be chest pain. And this is provoked. This is caused by vivid dreams. Vivid dreams. Maybe you'll be dreaming and somebody will be chasing you. So these vivid dreams will precipitate this angina. So when you get in your sleep, you get chest pain. We term it as nocturnal angina. And patients with this, patients who normally develop nocturnal angina are patients who comes with left ventricular failure. Left ventricular failure. So depending upon the position, the way you sleep could provoke the nocturnal angina. So what would be the position? If I say recumbent position, what does it mean? What does it mean if I say recumbent? What does it mean when it's a recumbent position? What does it mean? So nocturnal angina mostly comes with patients with left ventricular failure. Left ventricular failure. Left ventricular failure. Variant angina or Prince, mental angina. So this is angina. This angina can even be provoked even at rest. Without any provocation, patient can develop this variant angina. And this variant angina is as a result of coronary artery spasms. So when a patient is experiencing spasms such that it obstructs the flow of oxygenated blood via the coronary arteries to the myocardium, leading to or causing chest pain. That chest pain will be termed as variant angina or Prince mental angina. Is it clear? Is it clear?
Yes, please.
So we have decubitus angina. Decubitus angina. This angina occurs when a patient is trying to lie down. On lying down, this chest pain also ensues. One is nocturnal when you are asleep, but when you are trying to lie down, then this pain would also come. And normally, patient with left ventricular failure will develop that. One that's impaired left ventricular function will develop that. Okay, so this is the decubitus. When you are trying to lie down, there's a chest pain. The last one is the unstable angina. Unstable angina would occur even at rest. You get the chest pain even at rest. It means that the plaque forming is not stable, and the plaque forming could break. So there could be rupture, or part of it will break, or the whole plaque will dislodge. When this happens, this plaque, the ruptured plaque, can go and occlude smaller coronary vessels, coronary vessels, and these smaller vessels will be occluded. And when these smaller vessels are occluded, when we are even asleep, it will cause myocardial ischemia that would cause the chest pain. So unstable angina can even occur even at rest. When you are asleep, can even occur. So that is that.
Hello, Dr. Attakorah. Sir, please, can you take it from where you said the plug could break off? I didn't get it.
What did you hear? What did you hear?
So you said it's unstable because even at rest, the person who can get the pain and
Hey. Don't Benedict, are you getting broken at?
no, please.
So what? We have unstable angina. An unstable angina patient, I'm saying that unstable angina patient could have the episode, which is the chest pain, even at rest. And I was trying to explain that when you have these plaque forming, this plaque formed within a big coronary arteries, there could be dislodgement. The whole plaque could dislodge, or there could be rupturing because it's unstable. Note, the unstable angina comes with unstable plaque. Stable angina comes with stable plaque, such that when it's stable, you are doing activity. The heart will be demanding. There will be increase in heart rate. That will demand for more oxygen. But because you have a stable plaque, it would now obstruct part of the lumen, and therefore part of the blood will be blocked. So the myocardium will not be getting sufficient blood. Now, in unstable angina, this is what happens. The plaque, which is within the corona forming, is unstable. I'm saying it's unstable, and because of that, any pressure hitting it could cause it to dislodge. The whole plaque will be dislodged. This whole plaque, there could be part of it breaking, or there could be rupturing of this whole plaque. When this happens, then this will be in the blood, and the blood will take it to, now it's happening in big vessels. Then this ruptured plaque will move into smaller capillaries, smaller coronary capillaries. And these smaller coronary capillaries, depending upon the sizes of the rupturing or part of it breaking, at times this will not affect any. It will not cause any occlusion. The ruptured thing will be in the system, will be in the circulation. It will not cause any occlusion. Others, the ruptured plaque can also cause smaller, could go and occlude smaller capillaries. And when they does cause occlusion, they cause transmural. They block the smaller vessels. They block them. And when they block the smaller vessels, where the areas that these smaller vessels, smaller coronary vessels supply oxygenated blood will be affected. So even if you are asleep, there could be transmural total occlusion, and that will cause the chest pain. So two things can happen. Take note of this. Two things can happen. There could be ruptured plug, and this ruptured plug could move, will not go, will just be going through the circulatory, be with the circulatory blood or fluid or serum. It will be in the circulation without causing occlusion, depending upon the sizes. Some of the sizes are such that it will go and occlude smaller coronary capillaries. And if it does that, because it's causing total occlusion, these will prevent oxygenated blood in getting into the myocardium. Therefore, ischemia and infection would ensue. Is it clear? Benedicta?
Yes, please. Thank you.
So two things can happen. There could be rupturing. So if it's causing, that is why we say that unstable angina, even at rest, the patient will be getting heart attack. Meaning that when there's rupturing or part of the plaque, when you have these parts breaking, this part can occlude the smaller coronary capillaries. Or two things. Or the plaque will be in circulation without occluding, depending upon the size, without causing occlusion. And this is more dangerous. This is more dangerous. So why? Because you may not know when it will go and occlude. Maybe you'll be at a place where hospital is no closer, then there will be an occlusion. You are asleep. So they will say these things. The person is not sick. The person, I saw this guy, I saw this woman, I saw this, but it's no more than he or she slept and through that died. It could be all these things. This plaque will be moving within the system. The ruptured plaque will be moving within the system, can cause PE. It can also cause occlusion to the coronary vessels. And this would damage the myocardium. So these are some of what types of angina. These are types of angina. Any question up to this point? Any question up to this point? Any question up to this point?
No, sir.
Okay, so how do you diagnose? How do you diagnose this? How do you diagnose coronary artery disease? So we have something called coronary angiography. That's the gold standard for assessment of coronary artery disease. Please, can you mute for me? Can you mute? So we have gold standard coronary angiography. Coronary angiography is that we so what we do, the details is, I don't know whether the details are needed. We pass radio opaque contrast media. It's injected. There's a substance that is injected into the coronary arteries. We call it radio opaque contrast media. We inject this into the coronary, then we take X-ray will be taken. X-ray will be taken. That is coronary angiography. This will be taken, and this would locate. This will tell you that there's plaque forming. The X-ray will show, depending upon the media. The contrast media will tell you that there's plaque forming. To show the plaque. So that is the gold standard. We use coronary angiography to diagnose that coronary artery disease. It would show you where the plaque is, such that if surgery is needed, they can go in and take it from there. If even they give medication, and the medication, we expect that the medication will break the plaque. If they give the medication, they can do coronary angiography to check whether the plaque is no more there. The slices of the plaque is no more there. So this is the gold standard. So how do you manage this angina? Do you know what? I'm contemplating whether to do acute coronary syndrome. Then I talk about the management, or I should do the management. Then I finish with, because there's a management. How do you manage this angina? There's another level, which is acute coronary syndrome. How do you manage this acute coronary syndrome? So how do you manage stable angina? How do you manage exertional angina? So what should I do? Should I do the management? Or I should do acute coronary syndrome? Let me do the management. Let him do the management. So management of stable angina. Management. How do you manage it? When it gets to a certain type, like virulent angina. Virulent angina. What will you do when a patient comes with virulent angina? Hello?
Hello, Doc.
Yeah, I'm listening.
Please, the investigation, is it only the coronary angiography that can be done?
When I get to acute, I will tell you acute coronary syndrome. I will tell you other investigation that could be done. Do you get it?
Yes, Doc.
You get it. That is why I was contemplating whether to do acute coronary syndrome, because you can do ECG. You can also check the troponins. You get it. But
Yes, Doc.
when I get to acute coronary syndrome, all this. But for now, the gold standard is to do what? Coronary angiography. We check the plaque. We could do ECG. We could do cardiac enzymes. All these are there. Okay, so So what should we do if a patient comes with? Adam, what are you saying? You cannot talk. Adam.
Yeah, boy.
You cannot talk, Adam. Okay, so management of stable angina. What?
You are saying the PCB can be used for the angina.
So calcium channel blockers can you use beta blockers?
No, sir.
Why? Why can't you use beta blockers for variant angina?
So beta blockers causes vasospasm, so they are not using for presmental angina. This is caused by vasospasm.
Beta blocker will cause one.
They causes spasms.
Beta blockers causes what?
Coronary artery spasms.
Coronary artery spasms. Hey. Beta blockers will cause what? Who can tell me? Beta blockers will cause what? Hey, the whole class, I'm asking you, beta blockers will cause what? Is it spasms? Hey, beta blockers will cause what? Seriously? You cannot tell me. You're telling me beta blockers will cause spasms. Serious? Beta blockers will cause what?
Vasospasm.
Hey, you are also saying vasospasm. Beta blockers will cause what? Hey, lads, seriously. Hey, look. Beta blockers will cause what?
Hello?
Hello.
Doc, I think they will slow down the heart rate and reduce oxygen demand to the heart. Therefore, it's not good to use beta blocker in angina situations.
Hey, yours is also serious. That is the best. That is the best drug.
And for the
Ama, Adam, you coming? Ama, the best drug is beta blockers in angina. But I'm saying that in variant angina, can you use beta blocker in variant angina? Can you use beta blocker? Yes or no?
Doc, can I come again?
Yes.
Okay. I think beta blockers will reduce the myocardial conductivity and thereby slowing the heart rate.
You are not understanding my question. My question is that can we use beta blocker in variant angina?
Yes.
You can use
No,
beta
no,
blocker.
no. Doc, they are contraindicated. They can't use it.
They cannot be used, Dr. Attakorah.
They can't use.
So I want the reason.
Yeah, Doc, the reason is that it will reduce myocardial contractility, thereby slowing the heart rate.
What
So,
you are saying means that it can be used.
but it can also normally it also increase the coronary artery spasms in the various
It will not cause spasms. You are keeping on saying spasms. It will not cause spasms. Hey, beta blockers will cause what?
Hello, Doc. Please, I think that they'll cause blockade of the beta blockers and then leave the alpha blockers.
Doc, please, they cause coldness or numbness at the extremities.
Jemima, how will it cause? How will it cause the numbness and coldness? And I want you to use the right word.
Vasoconstriction. Sister, please, they'll increase vasoconstriction.
It will cause vasoconstriction, not spasm. There's a difference between constriction and spasm. Hey, you think it's the same? Plus, do you think it's the same? What is the difference? Spasms and constriction. What is the difference?
Constriction is narrowing of the vessels. Then spasms will be the irregular movements of the lining of the vessels.
What is irregular movement? How do you describe the irregular movement?
No, please, that's how I understand it.
I'm asking you, Ajimema, you are telling me that's what I'm asking you. When you are learning, be critical. You don't just brush it. Open your eyes. If I want to push you in these small things, I will push you. You are a clinical person, and don't just open your eyes. And when you are learning, beta blockers will constrict, will not cause spasms, will constrict the vessels. When it's constricting the vessels, it means that when a patient comes with spasms, it would now exacerbate it. Spasms are it will constrict and relax. That is spasms. There's constriction and there's relaxation. Constriction and relaxation. That is spasm. Constriction does not. It will constrict it, causing narrowing. But spasms, there will be constriction and it will relax. It will open up and it will constrict again. You get the difference. Yes or no?
Yes, sir.
Yes, sir.
Yes, please.
Huh? Therefore, beta blockers will constrict. The vessels will not cause spasms. It constricts the vessels. That is why beta blockers will cause coldness.
So I have a question.
And the mask.
Please, can we use the since it has that nitric oxide additional property where it can help with the vasodilatation?
So why are you doing this to yourself?
I'm just asking. Get the thought that
And
was
why do you do this to the patient? At the end of the day, what are you trying to achieve?
the dilatation of the vessel and then preventing the spasm.
So the same you are using, you say, can you use Nebivolum?
Since it has the nitric oxide additional process.
So when you do this, the same drug could constrict it, and that same drug could what? So what are you at the end of the day trying to achieve?
Okay, they'll cancel that.
That's what I'm asking. What do you at the end of the day trying to achieve? So
okay, I get it.
You won't achieve anything. You want that to, at the end of the day, the spasms will go on. Okay, so in Nigeria, Ama, is Mr. Ama around? Is Mr. Ama around? Yes. Is Mr. Ama around? So do you know that you go to London and some of Ghanaians who are at London, they are not using their names. So they will go and take somebody's paper. So if the name is Amma something and it's called Benedicta, and they'll be mentioning Amma, then the person will be there. The same thing. That is why I said use your real name and mention Amma. It's not responding. You are using different name on this. Okay, so management of stable angina, how do you manage it?
Dr. Attakorah, please, I have a question. Dr. Attakorah.
I'm listening.
Yeah, please, I want to know if it doesn't cause the vasospasms. You made mention of the spasms too. So where does the spasms come in relation to the beta blockers not being given in various angina?
I made mention of what?
Spasms. You said it would cause vasoconstrictions at the extremities of the blood vessels, and you made mention of the spasms again. So where does the spasms come in? I'm confused. I don't understand.
You'll be confused. And I want you to be confused. Because when you are learning, you want to learn it, then you go. At times, when I'm on the panel, I try to be flexible. Because that is your last hurdle. So if you punish the students, it will not go. So I'm so flexible when I'm on the panel. But if I decide to push you, you are confused about this small thing. Because all that you know is that beta blockers will cause spasms. Spasm, when we say spasms, two processes occur in spasms. There will be contraction and relaxation. Contraction and relaxation. That is spasms. Antoinette, do you get it?
Yes, sir.
So contraction or constriction and relaxation is spasms. When you talk about beta blockers will do one part, will constrict it. It will constrict it. That is what it will constrict the vessels at the periphery. So coronary arteries, which is at the periphery, to constrict it. So when a patient is having spasms, which includes constriction and relaxation, and you are given a drug, that also will cause what? Constriction. Won't it worsen the spasms?
Yes, it will.
So why is your confusion?
Confused anymore. Thank you.
Hmm? Okay, so beta blockers shouldn't be used. Listen to me. Beta blockers shouldn't be used in variant angina. But beta blockers in other anginas, beta blockers can be used. And it's the mainstay. The reason why other anginas, beta blockers will be used is that it will reduce. Can you hold on for a minute? Hello.
Hello, sir.
Yeah. Okay, so class. Let me do one thing and leave you. I've gotten a visitor and they are from outside. So they don't know this place. So I have to go and attend to them. To go and take them home. So
Yes, please.
let me say this. For management of stable angina, two things. We think about relieving or preventing symptoms. Relieve or preventing symptoms. And also think about improving prognosis by preventing MI. So what are the medications that could relieve the symptom? What are the medications that would improve the prognosis? So next time that will be coming, we'll be looking at these medications. We're looking at medications that will improve the prognosis. We're looking at antiplatelets, and we're talking about antiplatelets. We're talking about antiplatelets. So if I'm able to come to campus tomorrow, I will call Matthias. If I'm able to come, there's a funeral, but when I finish, I'll pass by. If I'm able to come, I'll call, then we continue. We continue the class. If not, then if Sunday too, and when I want to rest on Sunday, I would be meeting you on Monday. Do you get it? If class, let him know. If I decide to meet you in the morning, would it be okay for you? Or
yes. No.
You have class in the morning.
No.
you have class in the
morning. You have a class in the morning.
Come again.
You have a class in the morning.
Which class and which time?
9 to 12.
9 to 12. Dr. Bobo. Is it every day?
That's
okay, so if the mornings will not do, let's keep it to the evenings.
Thank you.
Okay, so see you. Good night.
Good night.
Good night.
Bye.
Thank you, sir.